Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you for joining us for the latest in our series of Policy Spotlight discussions. Policy Spotlight is a series of virtual events that Health Affairs launched last year, featuring in-depth conversations with influential health policy experts. Previous spotlights have featured CMS Administrator Chiquita Brooks-LaSure, CMS Innovation Center Director Liz Fowler, and most recently, Nikayla Cook, Executive Director of the Patient-Centered Outcomes Research Institute, or PCORI. If you missed these events or others, you can find them all archived on our website. If you're watching us live today, you can submit questions through the Q&A box in Zoom. I'll try to get to as many of those questions as I can. If they come in early and if they're brief and to the point, it makes it more likely that I'll be able to fold them into our conversation. But I'm really thrilled today to be able to introduce our guest and have a conversation with Admiral Rachel Levine, Assistant Secretary for Health in the U.S. Department of Health and Human Services. Admiral Levine oversees the department's key public health offices and programs, a number of presidential and secretarial advisory committees, 10 regional health offices around the nation, the Office of the Surgeon General, the U.S. Public Health Services Commission Corp, one of the 8 uniformed services. Dr. Levine is a pediatrician, and prior to joining HHS, Admiral Levine was focused on the intersection of mental and physical health, treating children, adolescents, and young adults. Admiral Levine was a professor of pediatrics and psychiatry at the Penn State College of Medicine. Earlier was vice chair for clinical affairs for the Department of Pediatrics and chief of the Division of Adolescent Medicine and Eating Disorders at the Penn State Hershey Medical Center. Admiral Levine, welcome. Thank you so much for spending an hour with me and our audience. It's such a privilege to be able to have this conversation with you.
Well, thank you so much. It is really a pleasure to be here.
We have a lot of ground to cover. I'm sure we won't do all of it, but just to get us started, it would be great to have you situate yourself a little bit just within the Department of HHS. And then I want to walk through some of the priority areas that I know you're focusing on and give you the opportunity, of course, to go into more depth. But maybe just at the outset, you could say a little bit about not just the org chart stuff that I said at the outset, but what does it mean to be the Assistant Secretary of Health?
Well, thank you so much. You know, it is truly an honor to have been nominated by President Biden and to have been confirmed in a bipartisan vote by the Senate to this position of the Assistant Secretary for Health. As you pointed out, I have a number of offices that I oversee. One of the very important jobs that I have is to oversee the Public Health Service Commission Corp. And it is an amazing honor to have been able to take my commission and to wear the uniform as a 4-star admiral in the Public Health Service and to lead 6,000 dedicated medical and public health professionals that work every day throughout our nation and even internationally for medical issues and public health issues. You know, the Secretary has called us the connective tissue of the department, and I think that that's very accurate. We are those our office is the conveners. We pull together many different divisions within the Department of Health and Human Services, other departments across the administration to look at and then work on specific public health concerns. Examples include long COVID, include climate change and health, ending the HIV epidemic and more. So we are the conveners, we pull people together, and then we work to solve the public health issues that face our nation.
Well, connective tissue is a really important role, and we'll talk about that. You know, since you started with the Commission Corps, why don't we just talk about that for a moment? The Corps was very involved in the COVID-19 response. Can you say a little more about what the role of the Corps was in and still is in addressing the pandemic?
Sure. So again, approximately 6,000 officers in many different medical and public health fields, and they have regular positions. They might be working clinically at the Indian Health Service or the Federal Bureau of Prisons, or be working in public health in research at NIH, FDA, CDC, et cetera. But then they deploy. We are America's health responders. And so we have been deployed as never before for the COVID-19 pandemic. You know, when we think of it, for a public health service, this is essentially our equivalent of a war when you compare us to, for example, the armed services. So there have been well over 4,000 deployments of our officers across the nation to do testing, to deliver medical care, to give vaccines and more in response to COVID-19. In addition, we have also deployed for the unaccompanied minors mission at the border. We have also deployed for Operation Allies Welcome for refugees from Afghanistan. And then there are the usual deployments for hurricanes, floods, and tornadoes. And so it is an amazing effort by our America's health responders that really, again, work every day for the health of our nation.
I'm going to change subjects a little here. Thank you for explaining that role. I'm actually right now at the Aspen Ideas Health Festival, and just this morning was at a breakfast with CDC Director Rochelle Walensky talking about climate change, and talk about a connective tissue topic. Climate change reaches so many dimensions of health and outside of health, and I know this is an area of focus for you. So could you tell me a little bit about the role of the Office of Climate Change and its relationship to health equity? And we're going to stick with this topic for a little while because I just think it's such an important one, and one that our understanding of it and how to respond to it is very much emerging at this point.
Absolutely. So thank you so much for emphasizing this topic. So we have a new Office of Climate Change and Health Equity. So we put it right there in the title that we're looking at the health impacts of climate change, but we're going to be using that health equity lens. People have spoken in before about the existential risks to health from climate change, and that somehow implies that these are risks for the future. But actually, these risks are right now. We are seeing health risk from, for example, extreme heat throughout the United States, from wildfires, and then the smoke from wildfires that have been exacerbated by climate change. We have seen the impact of hurricanes and other storms and flooding, again, stoked and exacerbated by climate change, sea level rise, and more. I've had the opportunity to in the last number of months to go to places as varied as Seattle, Washington, the South Bronx in New York City, Albuquerque, New Mexico, San Jose, California, Los Angeles, California, and I'm going to be in Orlando and Miami next week. All of them have extreme heat issues. They have extreme heat islands and domes that really threaten people. And again, it's those same individuals that suffer health disparities for other reasons and other causes that suffer the most from extreme heat. We've heard about, of course, the impact of forest fires, but then the smoke from those fires really impact people with lung disease, and I guess, again, those with the most health disparities. And so health right now has a seat at the table. Secretary Becerra has a seat on the National Climate Task Force. He spoke last week. I'm pleased to support him on that task force. I had the honor of going to COP26 in Glasgow, Scotland, and represent the Secretary in Health and Human Services. And in Scotland, we signed on to the COP26 health program. And that means that we're going to be working on the resilience of health systems to the impacts of climate change, and actually work to decarbonize the health sector. So all of those different issues are on the agenda for our Office of Climate Change and Health Equity, again, serving as that connective tissue with the CDC and Dr. Walensky, with the NIH and other offices within HHS, and then working, of course, with the EPA and others across the administration on these important health issues.
As a policy journal, we talk a lot about payment policy and performance outcomes for the health sector. And you listed a number of major divisions within HHS, but one that didn't come up was CMS, the Centers for Medicare and Medicaid Services. We're in the midst of big changes in how we pay for healthcare and what we hold the healthcare sector accountable for, trying to move away from just paying for delivering each individual service to looking at the health of populations, looking at outcomes. I wonder if there's an agenda for integrating some of the climate goals into payment, whether it's, as you mentioned, decarbonizing the sector, or thinking about climate effects as one of the outcomes that needs to be considered as we think about how we pay for healthcare?
Well, we're going to work with all of the different divisions across the Department of Health and Human Services, including CMS, and we will be looking for different policy levers that we can do to encourage hospitals and health systems to develop that resilience and to work to declimatize. So I don't have what those specific levers might be right now, but we're going to be looking across the board. I do want to point out that the executive order that the president signed a number of months ago actually commits the federal government to really across the federal government to those two actions, resilience and decarbonization. That includes the biggest health system in the country, which is the VA, and it includes the Department of Defense, and then other divisions within HHS, for example, the Indian Health Service and HRSA. What we're doing now is working with the private sector on those two initiatives. Now, we have a very close collaboration with the National Academy of Medicine, led by Dr. Victor Zhao. There is a climate change collaborative, of which I'm co-chair with Dr. Zhao and others. And we have been meeting now for almost a year to discuss these issues. And I want to point out that there is actually going to be an event at the White House a week from today, on the 30th, about this issue. And we have had numerous hospitals and health systems, as well as other companies, pharma and other companies along the supply chain, who have signed on to this pledge to work on resilience to the impacts of climate change and to decarbonize. And those that signed to the pledge have the ability to come to the White House next week and to sign their pledge at the White House. And of course, I'm very pleased to be there.
You mentioned equity as a core dimension of addressing climate change. And I'm interested in the special aspects of equity. On the one hand, climate change in and of itself has very inequitable consequences. The burdens of climate change are disproportionately borne by those with fewer resources. The resources needed to be resilient are less available to those with fewer resources, and so the impacts are greater. So at one level, you could say the entire climate agenda is a health equity agenda. But when you add the term health equity to the end, it makes me think there's more to it than just the inherent equitable dimensions. So can you help me understand sort of what is the additional equity lens on top of thinking about climate?
I think that we have included health equity in the title of the office to emphasize that equity, those equity issues are going to be not just at the end of the tail end of what we're talking about, but it will be embedded in all aspects of what we're talking about. Let's look at extreme heat. And so if you are of means in the various cities that I have discussed and you have air conditioner, and central air conditioning, then you're going to be much less impacted than if you can't afford air conditioning in any of the different cities that we've talked to. If you live on beautiful tree-lined streets, then you have shade. If those trees have all been cut down and you live in less fully developed housing, then you don't have the advantage of that type of shade. And so we have learned from some of those local cities about exactly what they're doing. We heard about planting trees, for example, in New York City, in Albuquerque, in San Jose. We learned about ways that Seattle is looking to cope. Of course, actually, most people don't usually need or have air conditioning in Seattle, but when it's 105 degrees in Seattle, people suffer. We went to Harborview Hospital and heard about seniors that had heat stroke, and tragically some seniors that died. So this is an issue throughout the country, and we want to make sure that communities that have suffered severe health disparities, particularly the African American community, the Latino community, the American Indian Native Alaskan community, that all those communities are front and center in the work that we're going to be doing, looking at these health impacts of climate change.
When I look at the global efforts around climate change that you referenced being a leader in, at least from where I sit, which is pretty far away from those conversations, I mostly see focus on reducing the decarbonization side, the reducing the pace of climate change, the trying to reduce emissions, not just focused in healthcare. I've heard less about global efforts on the resilience side, on the response side. And I wonder if there are things we can learn from other countries that you've been exposed to in your role that can help us not just be part of what obviously have to be global efforts to reduce the pace of climate change, but are there global opportunities also for responding to it and being better prepared for the parts of it that are already happening and maybe are unavoidable until we turn around some of our emissions problems?
Well, one of the lessons of COVID-19 that is applicable is that we are all interconnected. So literally the decisions that each one of us make and that our businesses and hospitals and our governments make literally impact our nation and the world. And so we're all in this together. And so I think that we certainly can learn from the successes and challenges from other countries. For example, I had the opportunity at COP26 in Glasgow to meet with the National Health Service of the United Kingdom. The National Health Service that's functioning in England, but also in Scotland and other places, about how they are working to develop that resilience and to decarbonize their health system and the successes and challenges that they faced. We've had meetings virtually, of course, about that same fact. So I think that we all can learn from each other, and we can keep the ball moving forward.
I want to move into another topic. We'll cover as many as we can today. Of course, we have a new Supreme Court decision this morning in Dobbs. We're not going to review that. Everyone's still digesting the opinion. But if there's one thing that's clear, it's that gender issues are highly politicized in this country. And one area where we see this play out is in gender affirming care. You are trained as a pediatrician, you've worked in this area. It's very hard watching clinical health issues become political footballs, but that's what they are. And so I wonder if you could help us understand the clinical side of this, the medical side of this, the evidence-based side of this, and help us understand if there's a way forward on these issues that is really based around medical and clinical evidence, setting aside, of course, the political challenges associated with these issues.
Well, thank you for that question. And it really fits squarely into all of our work on health equity in general. So this is health equity as it applies to the LGBTQI+ community, and particularly to the transgender community and to gender diverse youth and adults. LGBTQI+ individuals, and particularly youth, suffer health disparities and health inequities. They are more likely to have health issues and more likely to have mental health issues, particularly depression, anxiety, risk of suicide, etc. But I want to make it clear, there's nothing inherent with being LGBTQI+. There's nothing inherent with being transgender or gender diverse that would predispose someone towards these mental health issues. It is the bullying, the discrimination, and harassment that LGBTQI+ people face, youth face, particularly transgender youth, that lead to these negative mental health issues. Studies show that transgender youth that are affirmed by and accepted by their family and community and receive evidence-based evaluation and treatment have excellent mental health outcomes. They also show that transgender youth that are not accepted by their family or community and do not have access to the state-of-the-art evidence-based care have significantly more mental health issues. So from my perspective, gender-affirming care is medical care. Gender-affirming care is mental health care. And gender-affirming care is suicide prevention care. There is a strong evidence base for gender-affirming care for youth, adolescents, and adults. And the standard of care is established by an international organization called WPATH, or the World Professional Association for Transgender Health. And it has a US arm called USPath. And there are regular meetings and journals and research that is done and has been going on for a number of decades now, and a very strong evidence base for the standard of care treatment. Now, WPATH's previous standards of care were published in 2011, and they are coming out with a new standard of care in this summer. So in this summer, we will see the 8th edition for the new standard of care for youth, for teens, and for adults, and for seniors. The evidence base for this, again, is very, very strong. For youth, where a lot of these questions have come up, much of this care is provided at our nation's children's hospitals. You know, I've been in Pennsylvania before I recently came to DC, and it's provided at Children's Hospital of Philadelphia, Penn State Children's Hospital, University of Pittsburgh Medical Center Children's Hospital, DC Children's Hospital, Children's National Medical Center in DC, Boston Children's Hospital in Boston, Nationwide Children's Hospital in Columbus, Ohio, Seattle Children's Hospital, I could keep going, across the nation by pediatricians, adolescent medicine specialists, pediatric endocrinologists, child and adolescent psychiatrists, and psychologists. So really quite expert physicians and psychologists and nurses and others and providers. And so we really feel that medical experts should be able to decide, you know, this treatment upon the best medical evidence, as we do with all other medical conditions. And that evidence continues to grow, and we make some changes and adjustments in the guidance, as we do in all other medical conditions. And so it is just extremely challenging that this issue has been politicized, and that states are getting into this space, which really should be between medical providers and young people and their families. So that is where we are. But many states have done this, from Texas to Florida to Alabama. I have spoken in Texas a month ago. I'm going to Florida next week to speak about this. And again, to emphasize that this is evidence-based standard of care, the way we treat other medical conditions, and we should let medical experts, families, and young people decide their own care.
I'm really struck by where you began the answer to that question. And it reminds me of the evolution that we've had around discussing racism. You don't have to go very far back at all, where the view that worse health outcomes for African Americans, for other minoritized populations in the United States, were viewed as genetically based, as something inherent in being Black, inherent in being Hispanic. And that would then explain away the poor outcomes because it was inherent. We've now come, I believe, to a large segment of the population understanding that those negative outcomes are the consequence of how the majority society treats people, how it allocates resources, the economic versions of bullying and harassment that you describe. And that if you strip those away, the underlying capacity for health is equal among all of us. It's just that we don't all have equal access to that. And you beginning by saying that the negative mental health outcomes of LGBTQI plus folks are that the baseline opportunity for positive mental health is no different. It's how society responds to that creates the difference. That's a very important, I think, and compelling place to start. And it makes me wonder if some of the evolution in broader understanding associated with racism is also applicable to the care you're discussing here.
Well, you know, certainly we have been dealing with institutional racism in the United States, and it has been extremely challenging for the African American community and other communities of color, and something that is an absolute priority for us at Health and Human Services and our secretary. And as I was mentioning with climate change, it isn't that we deal with health equity as one more thing over on the side. Health equity is the foundation of everything that we are doing at HHS. It is the foundation of every grant, of every funding opportunity that we have to show how we are incorporating and embedding health equity into everything that we do. And, in regards to some of our previous discussion, that includes the LGBTQI plus community. But we live in amazing times. We have a president and a vice president who see us in the LGBTQI plus community, who support us and who affirm us. I had the amazing opportunity to be with the president when he signed the executive order a week ago, talking about the importance of supporting the LGBTQI plus community at every level. I was able to stand next to the vice president and to Secretary Pete and watch the president sign that executive order. And he is charging us at the Department of Health and Human Services and our Secretary Becerra, who also is so strongly supportive, to act on these issues, as well as the Department of Education, who released Title IX guidance yesterday. So under the Title IX guidance, when it says you cannot discriminate on the basis of sex in education, that includes sexual orientation and gender identity. In the same way, when we interpret the Affordable Care Act by our Office of Civil Rights, we also are interpreting it when it says you cannot discriminate on the basis of sex, that includes sexual orientation, gender identity. And when all of those rules are commented upon and finished, that will interpret everything, all of our divisions and how we interpret the Affordable Care Act, just as the Department of Education is doing that for Title IX. At the same time, to that advocacy and those policy initiatives, the Department of Justice is taking action legally. They supported and wrote a brief for the case in Alabama that put their egregious law on hold and has stayed. And so we're going to have to work on all of those different in all of those different spheres to push against these politically motivated, egregious, and harmful actions and laws in the states.
I want to return to your connective tissue image. You alluded to quite directly, as is appropriate, the mental health issues related to gender health. Actually, I could have asked about mental health in the context of climate change as well. We know that there are mental health consequences associated with the stresses related to climate change. And of course, there are huge equity dimensions when it comes to mental health. So my question to you is, here's another topic where we do have particular agencies and departments tasked with mental health as a priority. We certainly have research institutes focused on mental health, but the gap between where we are and where we need to be is so large that no one of those divisions or departments can do this alone. So when you sit in your office, in your chair, how do you think about what the connective tissue is that's needed to take a very complex topic like mental health and move it forward and create more than the sum of just the individual parts that we've created in departments and divisions here and there?
Well, you're exactly correct. We are in a mental health crisis in our country that has clearly been exacerbated by the COVID-19 pandemic and the challenges that we have faced during COVID-19 as a nation. The president highlighted this in his State of the Union address earlier this year. And over the last almost year and a half now, our secretary has restarted the Behavioral Health Coordinating Council here at HHS. And so I am honored to co-chair the Behavioral Health Coordinating Council with my counterpart, Assistant Secretary Delphin Rittman, who's the Assistant Secretary for Mental Health and Substance Use. And together we are leading an effort under the Secretary's leadership and the Deputy Secretary's leadership, Deputy Secretary Palm, to bring together all of the divisions of HHS to deal with this issue. We have different specific subcommittees looking at the overdose crisis that is continuing to plague our nation. We're looking at have a specific subgroup looking at, or a subcommittee looking at youth mental health and the challenges there. A subgroup looking at workforce needs. A subgroup looking at the intersection between physical health and mental health. That's something that I have worked on in my entire career in academic medicine at Penn State, and then in my public service in Pennsylvania. and now for the nation. And so we're looking at all of these different aspects, working on really what the president and the secretary have called mental health transformation in our nation. And so those are the tasks that we have before us. And again, it's going to be all of the different divisions at HHS. So there are those task forces that include NIH and they actually include all of the different divisions, each one, but many are led by my office, the SAMHSA, but also CDC, NIH, FDA, others such as CMS and ARC and ASPE, and the whole alphabet soup of different divisions that we have at HHS are involved in this effort. And again, we're always going to include that health equity lens to make sure that we address the systemic health disparities that have existed.
I want to bring in a question we received from the audience, and I'm going to expand on it just a little bit. The question that was sent in was, do we need to transform our health system back to one centered on primary care, preventive care, integrated with community behavioral health? I think I can guess what the answer to that is, so I'm going to expand the question a little bit. We know that given the dramatic shortage of mental health workforce, for many people, the first interaction with the health system when they have a mental health need is with the primary care system, and you're a pediatrician. That's a common entry point, not a mental health professional, but a primary care professional. At the same time, we dramatically underpay our primary care workforce relative to our specialty workforce. And we continually place additional demands and expectations on the primary care workforce. Even as we say we want a primary care-based system, by the way, here are 10 new things you need to do. We're not going to take away any of the old things you had to do, and we're not going to pay you much more for any of this. So my question to you is, if we believe in a primary care infrastructure for many reasons, not just to address the mental health needs, but let's focus there for a moment. What do we need to do to support the primary care workforce so that they can play a larger role in addressing unmet mental health care needs, rather than just trying to forward those needs onto a completely overwhelmed mental health system?
Well, a very nuanced question. So we agree with you completely that that primary care has to also be transformed. And again, playing that connective tissue role, we're working really closely with other divisions within HHS on that topic, and that includes, of course, HRSA, a mighty agency that is very involved with primary care through our amazing community health centers, but then reimbursement for primary care, for incentives and loan repayment, et cetera, for primary care physicians, but then other physician extenders, which are critically important to primary care, nurse practitioners, physicians, assistants, and more. ARC plays a very important role in terms of primary care. CMS, many other agencies that people don't always hear about, such as ARC and HRSA. But a really critical role to expand primary care, to expand the primary care workforce, to work with physician extenders, improve payment models, and more. So all of that is being done, in addition to specifically working to integrate mental health and physical health, particularly mental health in primary care. So, for example, HRSA has worked for a long time on integrating mental health into their community health centers, where they have specific mental health workers in those clinics, so that they can be more seamlessly integrated with pediatricians and family physicians and more. Something I worked on at Penn State, actually, before I left, having child psychologists in the primary care pediatric clinics. But not only the primary care clinics, we work to integrate psychologists and access to psychiatrists into the specialty clinics as well. I can't tell you how many patients I saw in adolescent medicine with young people, adolescents with specialty concerns such as cystic fibrosis, Crohn's disease, heart disease, cancer, and more. So we need to look at many different levels to integrate medical care and mental health care. I'll give you another example, is that, I ran the pediatric, adolescent, and young adult eating disorder program at Penn State in academic medicine. And what I think about it, really, that was a mental health clinic to deal with eating disorders such as anorexia nervosa and bulimia nervosa and more, with outpatient treatment, intensive outpatient treatment, partial hospitalization treatment, and even hospitalization for the sickest places. And I, as a medical professional, was embedded in that mental health clinic. It's now how I reverse integration, we call it. It's not how I thought of it at the time, but that's actually what it was. And so I think those reverse integration models with behavioral health community centers and clinics are also important, where we might embed a primary care physician, a family physician, or physician extender in the mental health clinic, because that might be more their medical home if they have serious mental illness. So lots of ways that we're looking about this, and lots of innovative ways as well.
That's very interesting. Thank you. I don't know how much this falls in your purview, but right as you started to answer, two questions came in that were very similar, and they had to do with the role of information technology in addressing mental health needs. As I say, I don't know how much of that is in your purview, but if you want to add the IT and technology dimension, I'd love to hear it.
Sure. Well, I'll talk about that from several points of view. I mean, we do talk about the integrated medical record. Traditionally, mental health issues have been separate from that. But if you're going to integrate medical care and mental health care, then it makes it really difficult if they have separate medical records. Yet you want to maintain confidentiality of mental health treatment for patients. And so I think there are a lot of nuances of how to do that well. And so that might be an IT issue that is really sophisticated and that we have to work on. Another issue is in terms of telemedicine. You know, we have made forcefully advances in telemedicine during the pandemic, and we have been able to, under the public health emergency declaration, to be able to suspend many of our rules and regulations. So we're looking at all of those rules and regulations, again, connective tissue across the department, to see which ones should stay and which ones might go if and when the public health emergency is suspended. We don't want to throw those away if they've been incredibly important, especially for mental health, for telepsychiatry and psychology. So all of those IT related issues are being looked at. Now, telehealth also has a health equity component. It's really hard to do telehealth if you don't have broadband or cellular service. So you do need to include, for example, audio only telehealth on landlines if you're going to do that, because I can tell you, even from Pennsylvania, that northern tier of rural Pennsylvania has broadband challenges as well as even cellular service challenges. So you have to keep that health equity lens in play.
I'm going to change subjects slightly. Another equity issue, again, particularly in light of the court's decision today, is Title X, the Family Planning Program, which has been, like many others on topics of its kind, the subject of significant political pressure and some change of direction in the prior administration relative to the current administration. I wonder if you could say a little bit about the goals currently for Title X, what evidence-based policies you feel are needed at this point, and how those maybe contrast to where the program has been.
Sure. So Title X is such a critically important public health measure, providing family planning services as well as sexually transmitted disease testing and treatment services, cancer screening services, and more to women and men throughout the country, adolescents and those that require those services. I have to tell you that Title X has been in my blood. I worked in a Title X clinic in my fellowship at Mount Sinai in 1987. And I actually ran a Title X clinic when I was the head of adolescent medicine at Penn State in Hershey, Pennsylvania. We had a Title X clinic and I ran that clinic. So I actually know firsthand how important those services are. You know, one of the victories of public health over the last 30 or more years has been the consistently declining unintended pregnancy rate. It's been declining for 30 or 35 years, and the consistent decline in the adolescent pregnancy rate. And so it has been so important in a public health victory. That is based upon the work that is evidenced in Title X, in the Teenage Pregnancy Prevention Program, and comprehensive sex education in our schools that have led to many of those public health victories that I would like to think that everyone would agree on, although probably not. But the evidence actually in the pediatric and adolescent medicine literature and in the family planning literature is extremely clear about the progress that we have made. Title X is integral to that. So there were significant challenges in the previous administration with the gag rule that you couldn't mention abortion in Title X clinics. Many previously funded Title X clinics left the program, including all of Planned Parenthood and many other clinics throughout the nation. The program shrunk by almost a third and was significantly at risk. So we have made significant changes in the Title X program in the last year and a half. We have promulgated new rules and regulations at record time to get rid of the gag rule and to restore Title X to its previous robust level. And I'm pleased to say that we had an extremely active Title X funding opportunity and funding over the last year that has brought back, many of those clinics. One of the challenges that we've had is that we were flat funded this year. We had asked for significantly more funding in the 2022 budget, but we were flat funded. So unfortunately, we had clinics that were approved, but not funded because we ran out of money. And so we have asked for significantly increased funding in the 2023 budget. And we look to Congress to fully fund our program so we can fund those great clinics throughout the country that were found to be extremely appropriate and excellent clinics, but we completely ran out of money to be able to fund them. And we're looking for more funding with Title X. And as you said, that'll be even more important in light of the Supreme Court decision today.
I will note, just as we leave this topic, that in April, we published a paper that analyzed the provision of contraception under Title X before the rules that you mentioned implemented by the Trump administration. And in that paper, it was demonstrated that Title X funded clinics provided the most effective forms of contraception at about a 50% higher rate than clinics that didn't receive Title X funding. So the use of the availability of effective contraception is definitely tied to that program. And,
absolutely. It's one of the most effective programs that we have. And, it is an honor to run it and to work on it. And we need to fully fund it so we can continue our excellent work.
I will say, I've done these policy spotlights with a number of people in the administration, and the topic of health equity comes up consistently because it clearly is a priority, and it's woven into the language. For every topic that we've discussed in our short time together, you have also woven in the health equity agenda. I do wonder, though, if I've left out critical elements of equity that you would like to talk about. We've talked about in the context of climate, we've talked about in the context of mental health, but are there other dimensions of health equity that maybe I haven't asked you about that you feel, having made that a priority, that our audience should hear about?
Well, I'd like to talk about our efforts to end the HIV epidemic, because to me, that's a critical health equity issue. So, I'll tell you a story. So I started my pediatric residency program at Mount Sinai Hospital in New York City, in Manhattan, in 1983. And that was just at the beginning of the HIV/AIDS crisis. Of course, we didn't know about HIV when I started my pediatric residency program. It was just starting to be delineated over the course of those several years in the early and mid 80s. In pediatrics in New York City, we saw babies. We saw 1 and 2 month old babies that had contracted HIV/AIDS from their mothers at birth, what we call vertically transmitted HIV. And those babies would come in with opportunistic infections, unusual infections. And those babies all died. Every single one of them that we took care of died. Their mothers, who of course had HIV/AIDS, they all died. I remember seeing fathers whose lives and families were ripped apart. Some of those fathers also died. And we saw that really throughout my training program. We also, as I started to do more adolescent medicine, saw teenagers who contracted HIV from a number of different mechanisms. And now in 1986, 87, 88, and they all died, every single one of them. And then we started to see AZT, but that was of some but limited effectiveness. And eventually, through tremendous work at the NIH and CDC and many other places, Dr. Fauci and many people, Dr. Walensky and others, we have made amazing medical progress. We have a medicine you can take once a day that would keep your viral load at zero, or as close to unmeasurable. So it's undetectable. Your viral load of the HIV virus is undetectable. And that means that the virus is untransmissible. U equals U. We have a medicine you can take once a day in which if you are at risk, you will not contract HIV. We have PrEP, pre and post exposure prophylaxis. We have a shot now once a month, and we're hoping that that can be maybe every 6 months or once a year. We'll see with medical research that, again, it would be PrEP. You would not get HIV. We still have medical miracles to come, that are still being worked on, such as a vaccine and a cure. But we have made so much medical progress that if you had looked at me 30 years ago, it would have been a complete miracle. But we still have new HIV infections in the United States. And we still have an HIV/AIDS crisis. We still have people contracting and dying of this disease. And so the issue is in terms of health equity and the social determinants of health. We are not getting those medical miracles to the people who need them most. That is a health equity issue. And so we are working on that with our Ending the HIV Epidemic program at our office and CDC and NIH and HRSA and others. HRSA plays an incredible role, and a critically important role with the Ryan White program, getting those medicines to people who need it, but we're still missing vulnerable populations. And we are working hand in hand with Harold Phillips at the White House and the National HIV/AIDS program and their strategy. And I was there at the beginning of the HIV crisis. I want to be there at the end of the AIDS/HIV crisis. And that's what I'm determined to do. And it's those health equity issues that we need to deal with, and the social determinants of health to get those medical miracles to people who need them most, so we can accomplish our goal.
You did an amazing job of describing where we are and what the potential is that we really could end this. I'd like you to say a little more, though, about what it's going to take. You mentioned some programs, you mentioned addressing barriers, but identifying them and overcoming them are two different things. So I just wonder if you could give me a few more paragraphs on what it's going to take.
Well, it's going to take consistent funding, that we have asked for in our budgets, in the 2022 budget, 23 budget, and more. So it's going to take consistent funding to be able to accomplish that. It's going to take really working at the community level, at the local level. So of course, we set these national policies, but we need to work with state health departments. And of course, I ran a state health department. We need to work with local and big city health departments. We need to work with the community of those of lived experience. And we have to get into those specific communities that need us most, that are still contracting HIV. We need to make sure that we have that health equity lens, that we are talking the language that people need. We need to work with syringe service programs. We need to work with LGBTQ programs, and we need to look at the cross-sectionality, the intersectionality of these health equity issues in terms of race, in terms of ethnicity, in terms of sexual orientation, gender identity, at those intersections to get at the most vulnerable communities, the American Indian, Native Alaskan community, and more, to get to the people who need it most, to get into the streets, to be able to do this. So I met a community health worker with Harold Phillips when I was in San Francisco a couple of weeks ago. And what he was doing is he's a community health worker. He was someone of lived experience, both in terms of the disease of addiction and HIV. And he was that night, every night, he goes into the Tenderloin district of San Francisco, and talks with people about needle exchange, about other ways they might be using drugs, about HIV, linking to care for HIV and hepatitis. And again, that synergy that we have in terms of risk for hepatitis, risk for HIV, and the disease of addiction and substance use, and getting to the people who need it most. And he was going to the Tenderloin district that night, as he goes every night, to see patients where they are, where they live, the homeless population. That's what it's going to take.
Thank you for expanding on your answer. That's really very helpful. Admiral Levine, every policy spotlight I do, I finish with a question about your own career path. You're in a position of tremendous trust and responsibility. And I know there are people watching who think, I'd like to sit in that chair someday. Maybe they're much earlier in their career. Do you have any observations, advice? It's a very open-ended question,
Sure.
but I just want to make sure that before we go, you have an opportunity to say something to those who might be thinking, what would it take to be offered the opportunity to do the work that you're doing?
Well, first, I want to say that I have always been gratified by my work in medicine. And I would encourage people to go into medicine and all the different nursing and all the different medical fields, because all I've worked to do is to help people, right? So see patients and families and help them do education, clinical research, administration at academic medicine, academic medical center, and help people, which I think is an amazing career. I then had a unique opportunity to go into public service and public health at Pennsylvania and help people from that broader perspective. And now the amazing opportunity to do that nationally. But I never intended to be here. I was following my academic medicine path. I was a vice chair and a division chief. So what comes next, and a professor, what comes next? So maybe become a chair or vice dean or associate dean or something. But, I had an opportunity and I took it and I jumped, and I didn't quite know where that was going to lead. But I think that sometimes when opportunities come, you have to think outside the box and sometimes you have to just jump and take a chance. And I had that unique opportunity in Pennsylvania. And then I got this amazing text in January of 2021, asking if I would be interested in the position in the Biden administration. And once again, I took a leap of faith and I jumped, and here I am. And again, with this amazing honor and opportunity to help people and to serve in the Biden administration.
Thank you so much for sharing that story and that approach to a career. I will say it's a common answer that I get from people that opportunities, when they come, you have to really be willing to stretch. And if you do, you never know where they'll take you. So thank you for that. Admiral Rachel Levine, thank you so much for joining me today. I learned a tremendous amount. And I feel a much deeper understanding of your position, your office, the role that you play, and what you bring to this really critical job. And again, I'm sorry to keep repeating it, but I think the connective tissue image makes a lot of sense in such a far-reaching healthcare system that we have. We need people sitting in places saying, how do we pull the pieces together? How do we make the sum more than the parts? Because we have so many parts, and they're only going to achieve their goals if we are able to weave them together. And you've made it very clear that you see that as your role, and you've given some quite compelling examples of doing that. So I'm very appreciative of having you as my guest today and for the wisdom that you've shared. I will say to the audience, if you liked this policy spotlight, visit healthaffairs.org and sign up for other events, join our email list. We also just last month launched Health Affairs Insider, which is a membership program where you get exclusive access to certain content, like our journal club and professional development events and the like. In that vein, Tuesday, June 28th, just next week at 1 o'clock Eastern time, we'll have an insider event regarding career paths in health policy with Robbie Torbay, who's the president and CEO of Project Hope, which is our publisher. We have other events in July, including an issue briefing related to type 2 diabetes, which we'll be publishing some articles on that month. A lunch and learn looking at the Supreme Court term with, of course, focus not just on the case released today. We'll be talking to former New York City Health Commissioner Dave Choksi as well in a policy spotlight coming up soon. So if you enjoyed this, please come back and see some of those events as well. Again, with thanks to Admiral Rachel Levine, this policy spotlight comes to an end, and we thank you all for joining us.